Welcome everyone to another week of Telehealth Failure Secrets to Success. This week we're pretty excited. I'm on the personal level. It's like you're all over the news, right? You see opiate addictions. It's a huge impact on the healthcare. Again, all the raging, debates on the Capitol and so on. So this week we're very lucky to have Dr. Martinez join us. He's going to share some thoughts about his thinking on the related to telemedicine and telehealth. Again, I'm pretty excited to learn what he has to say. I think it's going to be a massive impact on the system. So I guess, Jeremy, before we start, actually, can you just share about I know you went to Harvard, all these things, UCLA, all these the big prestige. How did you, how did you get started? Why did you went to medical school? How did you get, into the whole addiction area?
Yeah, thanks for having me, Milton. I was interested in being a doctor from a very young age, and for a long time I thought I would be a primary care doctor, the typical doctor that you see when you go in and you get your health care. And as I was in medical school, what I realized was that the mental health part of treatment was something that really drew me in. My first interview with a patient was actually a schizophrenic patient who spent a long time talking about his delusions, how microchips had been implanted into his body, and I just kept listening and listening. It was fascinating. But the attending physician that was with me said, "Look, you got to stop. Get all this other information. That's part of the history that you have to take from this patient." He said, "You could listen to delusions all you want in psychiatry residency." And so I thought, oh, okay, psychiatry residency, that's an interesting idea. I never considered myself, becoming a psychiatrist. But drugs of abuse and how drugs affect the brain have also been very interesting to me for a long time. And in psychiatry, this is, it's one of the subspecialties of the field of psychiatry. So I ended up going into psychiatry, did some research on addiction treatment when I was in medical school, and all of my interest had just been reinforced in the ideas of mental health and specifically addiction treatment. And it's been very very fascinating. Unfortunately, like you said, there's a lot of attention now to addiction in terms of the opioid crisis. Unfortunately, the opioid addiction is something that is extremely fatal, and we're seeing people die from overdoses. So I do think that the telehealth issue does tie in very well with this problem as a potential solution.
Mm-hmm. Got it. Okay, thank you so much. I guess how about can you share with us something maybe like non-professional things about your background, just something maybe people get a flavor for you that's maybe not in the typical sort of academic bio.
Well, I am a pretty entrepreneurial person. Prior to coming to Matrix, I had run my own clinic, multidisciplinary clinic with psychologists, psychiatrists, an acupuncturist to do a multimodal treatment for addiction. I also ventured into trying to develop a supplement, a nutritional supplement for alcohol use disorders. So creating new businesses and new ideas is always something that's been very interesting to me.
Oh, super. Okay. Then in this space, do you have a favorite book or favorite podcast you recommend other aspiring entrepreneurs?
One podcast that I listened to for a long time was the Tropical MBA podcast, which is more focused on location-independent entrepreneurs. But the idea of trying to develop businesses that don't take a lot of your time so that you can be location-independent, that's something that has always been very interesting to me and is definitely worth checking out, I think.
Super. Okay. I think recently became a huge fan of Reid Hoffman's Master of Scale, which I thought really, really excellent podcast, just in terms of how do you think about entrepreneur, how do you scale into these massive enterprises.
Oh, that's an important part of it. I'm writing that down.
Yeah, I think these days we see a lot of physicians become entrepreneurs, which I think is really good things. And otherwise, you just have, if you let the normal big system just it's a fun innovation, all these is just too slow. It's better for physicians almost to take matter into their own hands, just to.
I think it can be. The problem is that we don't get much business training in medical school. So
Yeah,
when a physician finishes their residency and goes out into the working world,
yeah,
when they're working in private practice or running their own business, we haven't learned how to look at a P&L or how to use a
yeah,
spreadsheet to
yeah.
you make projections, and
Yeah.
so yeah, it's a challenge.
Okay, hopefully as your ventures take out, then later on you can maybe come back, give some physician tips on how they can repeat.
Absolutely.
Super, Truman. Thank you so much for the background. How about this? Maybe I know you have some slides you prepare. Maybe you could just share with us these sort of slides, and after that, we'll take some questions from the audience. We just have an open dialogue.
Okay, great. So these slides, this presentation is about technology and addiction treatment and how the newer modalities that are available to us might be helpful in providing better care. There are two general areas of technology that are used in addiction treatment. One is telemedicine or video conferencing, and the other is technology-assisted treatment, which is in the form of apps and other things like that. But why do we need technology for addiction treatment? We really need to start back and look at some of the problems that we're facing in the addiction field. One of them is that in the population, there's a general lack of recognition or acceptance of having a substance use disorder among individuals. So that's a piece that requires education, and technology may hold some keys to that. There are also a fair number of people who perceive a need for needing treatment but aren't accessing treatment. Some more traditional problems that we think about are low success rates in treatment. We have new modalities, especially for opioid use disorders, medication-assisted treatment, that may promise higher success, although there's difficulty accessing this type of treatment. So when we look at all of these issues, it helps us to understand why we would start looking at some of these things. In terms of the idea of folks that are drinking alcohol, for example, of those people who meet criteria for alcohol use disorder, or alcoholism as it's often called, about 90% don't really perceive a need for treatment. But there is a small fraction, 3.1%, that see that there is a need for treatment, but they haven't received treatment. And this is even more pronounced with illicit drug use, where there's another small sample of 5.7% that see that there's a need for treatment, but don't receive it. So that area might be something to target with technology. So when we look at traditional addiction treatment, many people are familiar with Alcoholics Anonymous or 12-step oriented treatment programs. There was a study looking at what the success rates were of these types of programs and following how many people actually went to 12-step meetings afterwards. For those of you that aren't familiar with what 12-step is, this started with Alcoholics Anonymous, which is a mutual self-help meeting. There aren't licensed counselors or therapists in it. It's a group of people who come together to help one another and follow the tenets of the big book, which give a strategy for how to support one another and live life. When they looked at this study, only about 20% of the individuals could be reached after a year. So that's only about 1,200 people. And of those people, about 67% attended 12-step meetings. 74% of those that attended 12-step meetings stayed sober. They didn't use heroin. And 62% of those that did not go to the meetings stayed sober. this should say did not use heroin, I'm sorry. So the point was that 12-step meetings are associated with better outcomes, but this is only 20% of people. So it's a very small population that that are doing well, especially as time goes on. Now, when we look at other things like medication-assisted treatment, buprenorphine is a medication that's also known as Suboxone or Subutex. This is one of the most effective treatments that are available for opioid use disorder. And when examining these patients over a year, about 57% stay in treatment, and of those people, about 65% didn't have any illicit drug use. So we see this larger population of people that with a medication like buprenorphine, here we see 53% were either unknown, were lost to follow-up, or weren't sober, versus 86% in the traditional treatment group. So what we're seeing is that having a traditional program may yield about a 14% success rate versus with medication about 47%. And this is something that's very important when we think about the fact that every relapse could end in death for someone. So one thing that telemedicine promises to do is to increase access to this type of treatment. So what I looked at was a study that had current trends, barriers, and provider attitudes about this type of telemedicine treatment. This study looked at 5 states and 1 county. In 2011, less than 1% of treatment centers were using telemedicine. There was a push through NIATEX, which is a program through SAMHSA. SAMHSA is a agency as part of the Health and Human Services that does substance abuse and mental health treatment. And technical assistance was provided during that period for many programs who were trying to implement telemedicine. When these providers were enrolled in the study, they were given a list of evidence-based telemedicine treatment options for them to choose from for implementation. At baseline, there were state-funded programs in Iowa that were already going using telephone-based treatment. Maryland had been starting an implementation of a program called Virtual World at the time of this study. In Massachusetts, 4 providers were using a mobile app called HS to help with treatment. And in Oklahoma, they actually had a state sponsored platform for video conferencing. So this is the list of the treatment modalities that each treatment center was able to choose from. It was either a telephone-based treatment, a web-based treatment, which might have been either video conferencing or some other type of computerized intervention. When these treatment centers were given all the different options, there was the most interest in video conferencing, which was followed by mobile applications. But in fact, all of the sites expressed interest in video conferencing, with the exception of Iowa, which preferred a web-based computerized system. And the primary interest in these sites in using video conferencing was to provide patients access to Suboxone. So for those of you that aren't familiar with the use of treatment with Suboxone, this requires a specialized DEA certification for a physician to prescribe Suboxone. A provider needs to go to specialized training. It's not something that every physician can prescribe. So there's an access issue with a limited number of physicians that are certified to prescribe this medication, and especially in rural areas, this can be a problem. So these states were interested in using telemedicine to help those in the rural areas. In terms of what these sites saw as the perceived benefit of teleconferencing, in Maryland they saw telesuboxone as an option to treat the opioid epidemic, giving greater access to physician prescribers. In both Massachusetts and Oklahoma, they saw this as a way to provide additional recovery support. In San Mateo County, they saw this also as a means to have greater access to physician prescribers of medications like Suboxone. And South Carolina similarly saw this as a way to potentially address disparities in access to care. One thing that we see in the addiction field is that, especially when Suboxone was brand new, fee-for-service providers, higher-end treatment providers were providing this to patients that had more funding. whereas in the Medicaid system, there was it took a little bit longer to get access to this medication. So so there are these disparities in care that happened that the hope was, anticipated benefit was that this might be able to reduce some of those barriers. Perceived barriers to implementing video conferencing were a few different issues. In Maryland, they found really a problem with the lack of willing and available doctors that were willing to prescribe Suboxone. So this was more of a lack of willingness or ability to prescribe Suboxone, more so than lack of willingness to use video conferencing. There was also a perceived barrier of limited reimbursement funding, and also difficulty with knowing what type of model to implement. In Massachusetts, their concerns were with HIPAA, which, for those of you that aren't aware, this is the healthcare law that prevents protected health information, patient information. There's also a law called 42 CFR Part 2, which is specific to substance use providers. So we have an additional layer of confidentiality that we need to meet, and that is a perceived barrier for some of these systems. In Oklahoma, they also saw that there was a limited reimbursement model at the time. So if you're going to provide these services, you want to make sure that you're getting paid for it. In San Mateo, they saw, and as well as in South Carolina, the competing priorities at this time, this was 2015, they saw the implementation of the Affordable Care Act as being a competing priority where their attention was split in different directions. So that was a perceived barrier. Now, reimbursement for telehealth has changed since this study was done. Right now, 47 states have policies regarding Medicaid reimbursement for video conferencing. The actual policies will vary state by state, and at this time, only 13 states have policies where they actually will reimburse at the same rate as in-person treatment. So there's some catching up to do in terms of the reimbursement for telehealth. This slide shows the dates when reimbursement policies were put into place in various states, and you can see that it was clustering toward the 2014, 2013 period of time. So this is something that just more recently has been put into place, and oftentimes policy struggles to catch up with technology. So that's something that we're seeing as at least a perceived barrier to telemedicine. In terms of the types of substances that are being reimbursed right now, we can see that psychiatric services and outpatient services are really the most likely to be reimbursed in any state. And unfortunately, substance abuse is on the lagging end of that. And like with other parts of healthcare, oftentimes substance abuse treatment does tend to lag behind in terms of parity and other parts of advancement in treatment. But this is rapidly changing. In April 17, the GAO put out a report on telehealth that was reporting that there was significant interest both on the part of patients and physicians to provide telehealth, and there have been several government demonstration projects that have been successful. The prediction by this report was that the merit-based incentive payment system, which is starting in 2017, may encourage more use of telehealth. So physician reimbursement is going to be shifted from the number of sessions that you provide a person to how is your patient doing overall. And using telehealth may be a way to keep in better touch with your patients and provide a higher quality of service in a time-limited clinic setting. Other studies have looked at the cost effectiveness of technology-assisted treatment. This looked at the Therapeutic Education System, TES, which was an internet-delivered version of some common addiction treatment modalities called community reinforcement and contingency management. The program was implemented at a cost of about $278 above treatment as usual for a 12-week program. Overall, the main costs were with the annual license, although over time the startup costs tended to be more significant than the ongoing maintenance of the costs. And when examining both health plan and state payers and providers and their attitudes about what willingness to implement a system like this, there was a willingness at those willing to pay $20,000 or more per abstinent year for patients. In that range, when payers or providers are willing to spend that much per year, that's where the cost effectiveness of this type of program seemed to go in the favor of using a system like this. The ideal cost effectiveness ratio for both payers and for providers was about $9,000 for a 12-week episode. And like I mentioned, most of the expenses are related to startup, not ongoing licensing. But this chart shows both the solid line is the providers and the dotted line is the payers, where they were most likely willing to accept paying for this type of treatment at an amount of about $20,000 per year as their total outlay for addiction treatment per year. In 2016, there was another survey that looked at patients in substance use disorder treatment and looking at their willingness to take on a technology-assisted treatment platform such as mobile applications. 83% of the participants were interested in using mobile applications to help with addiction. 91% of those had cell phones. Unfortunately, only 50% of those had access to the internet via their handheld device. So I think that's a consideration for us to look at as we're thinking about the development of mobile applications. Obviously this is going to be a moving target, how many people have access to the internet on their phones, but at least as of the time of this study, there was only about half of the population that had that feature. So in the beginning, I talked about those people who haven't accessed addiction treatment, that they, especially with illicit drug use, that 5.7% that perceive a need but haven't received treatment. And this is something that I've thought a lot about in terms of what it takes for a person to accept that they have an addiction problem and step through the doors of an addiction treatment center. I think that there is a very high barrier, a lot of shame that's involved, and there's a subset of the population that could benefit from a type of treatment that didn't require them to go into a treatment center. So this 5.7% of the population is a target for new addiction treatment modalities that are internet-based or web-based, and perhaps even telehealth. If a patient feels more comfortable using a telehealth provider rather than going into a treatment center. Now, in terms of Matrix Institute, where I work, what we're doing to increase access to treatment, we recently applied for funding for a hub and spoke model to expand the types of addiction treatment that are available in the community, with a base at our narcotic treatment program, also known as a methadone clinic. Those clinics are the experts in medication-assisted treatment and can spread that expertise to lower levels of providers. Down at the bottom, FQHCs, Federal Qualified Health Centers, are the primary care clinics for patients that are on Medicaid that are really seeing a need for access to this treatment but don't have a lot of providers. So as you can see in the bottom right, one of the ways that we can use this model is by providing telehealth to patients who are in different areas. So in terms of our preparation for designing a program to assist patients with access to care, we found that patients are very interested in the idea of telehealth and TAT. States and plans are also willing to pay for it at some level. States and counties are most interested in telehealth to provide access to Suboxone, which we know is a more effective treatment modality than traditional addiction treatment. Reimbursement barriers are have been a significant problem for a long time, and those seem to be resolved. The most progressive policies tend to be with Medicare and Medicaid, and among private insurers, they're catching up with creating policies for reimbursement. Sometimes those reimbursement rates aren't as high as the in-person treatment, so that's something that needs to be addressed. But this type of treatment may be effective at about cost-effective about $9,000 per 12-week treatment episode, which is still fairly expensive when you think about what a 12-week treatment episode of treatment could be as in an outpatient setting, such as at Matrix. We do outpatient treatment. That can be done at a fairly cost-effective rate also. But undoubtedly, these types of costs will come down. Some of my conclusions and what I would encourage people to think about is that providers, groups, and health plans should consider telemedicine or technology-assisted treatment as a modality to increase access to care, that it can be cost-effective and can increase access to specialty care, which is really one of the big barriers that we're seeing right now. More work needs to be done to improve provider willingness to prescribe Suboxone. So there are many providers that have been certified to prescribe Suboxone but aren't seeing that many patients for opioid use disorder, and part of that is a lack of training and a lack of comfort with seeing those patients, also a lack of time. So a hub and spoke type model like we're describing may be one way to provide those types of services with a specialty provider and have primary care providers continue maintenance treatment after the initial heavy lifting of starting the person on medication is done. So that's more of a general addiction treatment issue that we're seeing in the field, but the telehealth may be a helpful solution to assist us with that. Now, if that hurdle can be overcome, most of the other elements to provide medication-assisted treatment are in place to some extent. The policies, reimbursement, the fact that there are telehealth platforms that are HIPAA compliant and 42 CFR compliant, such as the VSee platform. So, maybe the biggest hurdle isn't so much the technology or the policy, but just back to the clinical issues of how do you treat addiction. So we're going to take questions now, but if anyone has additional questions for me later, I'm leaving my contact information here.
Joby, thank you so much for that extremely informative presentation. Thank you so much for that. But then one question I have is, like, for example, you had this where that the chart you showed, you had a massive, population where they perceive they really don't need the treatment in there. So what are your thoughts on how do you access that big pie? I feel like because everything else is such a small pie in there, if you don't touch that big pie of those population, then you're really not having a big impact on the overall problem.
That's a great question, and I think that education is part of it. These surveys are done by telephone surveys. We don't know to what extent people are willing to, share their own perceived need for treatment and how honest they are. But these have been replicated quite a bit, looking at both national studies and in LA County. We've had similar numbers. So I think that the technology-assisted treatment apps may provide an option to provide education for people who are in that realm of developing a substance use problem, and perhaps may get at that bigger piece of the pie. But you're right. I mean, that's the glaring truth of all of this, is that a huge number of individuals don't perceive that there's a problem with their use.
God, I guess if you can wave a magic wand, assuming like money is not an issue, everything is like you literally like what would be the strategy you feel you have the biggest impact in terms of reaching these people?
So I think some of the biggest impacts that we can have are in increasing the access to medications for treatment, not just the Suboxone or buprenorphine that we talked about. There's also a medication, naloxone, which is used to reverse overdoses,
Yeah.
and that's being distributed to law enforcement, and we have that in our clinics. So all of these different medications, do promise some higher treatment efficacy. So if there wasn't a barrier to cost, having lots of providers trained and prescribing these medications would be a policy move that I would undertake.
Got it. That makes good sense. That is, in terms of you demonstrate for the medication had this a huge improvement in the outcome there. I guess if you were to, let's say, prescribe this medicine by telemedicine, like how is there any safety issue? Like how do you need to check up on them? Do you need to have a nurse or medical assistant to watch over the, so like how's that like plan out?
That's a great question. Yeah, so these patients, sometimes these are psychiatric patients that they may be in a situation such as a patient that's suicidal, may need to be put on a hold and kept where they are, and that requires some type of staffing. So the model that I would espouse is a clinic that has a nurse available, or even if it has other physicians available that maybe aren't addiction specialty providers, to see the patients and can use the specialty provider when necessary.
Okay, got it. Okay. So when you, can I ask, like, for example, when the person started drug, how long does that, like how frequent does it take them? Like how long should be this watch period until they get safely maybe on their own?
That's a great question. And what we're seeing in the research is that in general, the longer that people stay on these medications, the longer they stay without any illicit substance use.
Okay.
So this is a very controversial topic in the addiction field, the idea of lifelong treatment with a medication like buprenorphine or methadone. The research shows, especially with looking at methadone treatment, over a 40-year period, people are much more likely to avoid drug use if they stay on the medication.
Yeah.
However, all of these decisions are on a patient-by-patient basis. So when I'm working with patients, I usually set up these guideposts of 6 months and a year to stop and reevaluate with them, how well are they doing in other parts of their life? Are they back to work? Are they involved in a 12-step program? So even though I'm showing this slide where the traditional treatment doesn't seem to be as effective, we do encourage our patients to be involved in 12-step programs. And for those who are very active, who are working steps and have a sponsor, those are the folks that I'm more likely to have a trial of tapering off a medication if they're active in their recovery.
Got it. Okay, that's really helpful there. Then the question I have is, for example, if you read the news, all these things, that like the cost for these for treatment, it seems to be all over the place, right? You have these for like a 30-day living program that something goes like from 30, 50, even like $100,000 for that treatment. But like how, like in the numbers you cited, is this much lower? How is like, why are those things so expensive? Is it just like branding, or is there like clinical outcome differences between you pay for, let's say, $100,000, $50,000, $20,000, or $9,000? Like,
that's a really great question, and unfortunately, a lot of families think that if they're spending more for treatment, that they're going to have a better outcome, but the studies have not shown that at all. Price really has no significant impact on the outcomes of treatment. So here in Los Angeles, we have several treatment programs in Malibu that may be in the $30,000, $40,000, $50,000 a year range.
Yeah.
We can't predict that they're going to have any better outcome than someone doing a less expensive program. The reason that they're so expensive is all of the amenities. Very nice high thread count sheets, being overlooking the ocean. These things are things that are really nice, and honestly, sometimes that's an important thing for a patient. If you consider a wealthy patient where that's kind of their baseline, and they're not accustomed to being in a staying in a bunk bed or having a different type of treatment environment. So some people actually need to have a treatment environment where they're where they're comfortable, where that they're willing to go into. But what's very sad is when families will, mortgage their house in order to pay for, a $100,000 treatment episode, and not getting any better outcomes.
I see, got it. Then how, assuming, let's say, the barriers for these or telemedicine, all these is broken, like how inexpensive do you think it could be? The reason I feel like there's like because the problem is so massive in there, like, do you have a sense of like how low it could go and still you feel like you'd be sort of effective?
Well, what's shown to provide the best outcomes is the length of time in treatment. So the longer a person can stay in treatment, the better they're going to do.
Okay.
Everyone's going to be at a little bit different place in terms of their addiction, their mental health issues, their environmental status, where some people are not going to be able to do an outpatient program because they are in a domestic violence setting, or somebody who's homeless, for example. They're going to need a residential type of treatment setting that's going to be more expensive. But there are a number of people that can do well with just outpatient treatment, and that's where things can get very cost effective, where something like $9,000 is a reasonable amount to consider for a treatment episode, depending on where it's located. So treatment can be very cost effective, and it certainly reduces other costs for society in terms of time spent in jail with law enforcement, other health issues, emergency room visits. So certainly, I think it's something that we need to look at as a society, that treatment is effective and cost effective.
Got it. Okay. So we have a question from the audience. Rebecca's asking. So like in terms of all technology, right? There's failures and security issues in there. Like, how do you still protect the patient's privacy? Is there something you need to do beyond just trusting the technology to be sort of HIPAA secure?
Well, I think I might divert that question back to you, Milton, because you probably know more about internet security and best practices than I do.
Yeah, so if I take a question to Rebecca is, so from VSee as well as a number of other companies, from the encryption perspective, typically it's very strong encryption, in fact, all these things. So usually those are not the weakest point. In fact, most of these internet breaches, what these things is like, people actually is like, your device itself become compromised, right? If you look at the recent Israel, WannaCry and all these different things, tend to be like you go to some website where your computer is not up to date with the latest patches in there. So usually that's the weakest link in there. So usually our advice, right? Definitely you want to make a vendor. The question is, are they, what are the things they're doing from a security perspective? Are they doing source code scanning? Are they paying third party to do penetration tests? All these things. Assuming they do all those things, then you more or less is as secure as it could be from the overall system perspective. In fact, most of those systems is fairly robust. It really does not come down to your individual provider, your patient, and is the computer up to date almost. Like if they are, then they usually do they have a virus scanner. So, we have another question from the audience, Franco. So he's asking, so what's the definition of alcohol or nicotine addiction? Like, how do you know that you belong to the categories that like you really should get treatment?
That's a great question. And so at a very basic level, addiction is continuing to do the behavior despite any of the consequences that arise from it. So if you see that you're drinking, every time you drink you end up driving and having DUIs, and you continue in that pattern and it's difficult for you to stop despite any of those negative consequences, that's a sign that addiction may be present. There's also physical symptoms of alcohol, for example, where somebody who's physiologically dependent on alcohol will start to get shakes or tremors on the days when they don't drink. They might have more anxiety when they're not drinking. It might affect their sleep. And so there's a kind of a societal kind of compromises of your functioning that happen from it, and then there's also a physical elements to it. And unfortunately, alcohol withdrawal can be fatal. So for people who are drinking very high amounts of alcohol, when they stop, they can have seizures and need hospitalization. But at a very basic level, it's, if you're continuing a behavior despite the consequences, it's time to ask yourself why. And I think one of the most sensitive things is looking at your relationship with your spouse or your significant other, where if they're upset by a behavior that you're doing, such as regular drinking, and then you don't want to quit it, it's time to start asking yourself why. What's this doing for me? And do I really have control over this substance?
Got it. That makes a lot of sense in there. Okay, we have another question from the audience. Derek, he's asking is for private pay patients. So what's your recommendation, the best use for the telehealth?
So the best use of their funds, it kind of depends on the person. There's different levels of treatment for someone who is having very significant withdrawal symptoms, like the alcohol that I talked about. They need to start out in a detox type of setting. And once that type of treatment is finished, then they can be stepped down to either residential or to outpatient treatment. But I do think that a very cost-effective way to use your money is to be involved in an outpatient program for a long period of time. So that's definitely something that I would say that's going to be vital for everyone. Where it's going to vary person by person is how much of the front end residential or detox treatment that's needed, and that's something that you really need a medical provider to assess and to help you with.
Got it. In terms of like the telehealth, right? You can use telehealth to think these are in a remaining therapy session or with a, let's say, provider therapy, or maybe this peer support group in there. Like if you had to only pick one of these two modalities for like which one you'll be more effective?
Either a peer group or a provider?
Yeah, it would have these for like maybe weekly counseling sessions.
Well, what we've seen from the research and in slides such as the one here, the medications have been some of the most effective treatments that we've seen. Now, unfortunately, not all addictions have a medication. There's no medication for methamphetamine use disorder or for cocaine use disorder. So unfortunately that's not always an option, but at least for opioid use disorder, medication has been shown to be the most effective thing. So having a regular visit with medication and, 12-step meetings, AA meetings are not, you don't get charged for those. Those are free of charge. So I always encourage people to get involved with 12-step, and that's going to be, that's not going to cost you anything.
Got it. Okay. I have another question from Deborah from the audience. So she's asking, how is success defined with a new push for the MAT? What are the ethical implications? Is there like difference in mortality rates?
Yeah, so there are definitely differences in mortality rates, and those data are very, very clear with methadone treatment, and that's been looked at over time. They're pretty shocking, actually, how many people will die from opioid use disorders and what a change a medication can make. How we define success, in this study that looked at buprenorphine, they defined it as no opioid use within the last 6 months. But that's also a very good question because there's different ways to determine success in addiction treatment. There's one thing we see that that happens with people when they get into treatment is that oftentimes their relationships get better, they get back to work, everything seems to be going better in their life, and I think that's something else that we need to look at in terms of what success is also.
Got it. Okay. So I have a question from the audience from Elizabeth. So she's asking, how do you see the role of the therapists, the SUD therapists in the sort of TAT framework?
Oh, so that's a really good question. So some of these modalities use a therapist and some of them don't. There's this question of reimbursement. If you have a computer program that's providing treatment and there's no therapist attached to it, it's unlikely you're going to have any kind of reimbursement model for it. So at the time being, these technology-assisted treatments are really that. They're technology that's assisting the therapist in what they're doing. So there have been studies looking at cell phone use, a cell phone-based program giving the patient encouragement. This was specifically done with teens, and so they have a therapist that they're working with, but on the rest of the week when they don't have the therapist, these apps can give them additional encouragement and can give them, warning signs if something, if they're entering an area that they know is a difficult trigger area for them. But certainly the role of the therapist is still very, very important for this. This medication can't replace the psychosocial treatment. It's just an add-on.
Okay. Thanks for that. So I have a question from the audience, Janet. She's asking, so how do you address issues of training your staff so they're skilled in this online service delivery? Do you have any sort of tech best practices for just getting all your staff trained?
Yeah, that's a great question. And some best practices revolve around the stability of the patient. Treating unstable patients in a telehealth environment is not always that safe. Having another best practice that many facilities follow is having an initial in-person evaluation of treatment, and then following up with telehealth. But I think one of the most important best practices is just the stability, making sure that the patients are stable enough to do that.
Got it. What about in terms of getting your own medical staff on board in there? Do you have a boot camp to get everything telehealth ready? So they, or do you just more organic? People just learn this on their own type of thing?
Yeah, that's a great question, because a lot of the implementation is focused on the technology itself and helping people to use the technology, but having those kind of best practices involved, that okay, what are you going to do if this person does need emergency care? How are you going to arrange that? So yes, the staff needs to be trained on how to plan for contingencies. So some of that would involve having the patient's address and knowing where they are when you're talking with them, because this can sometimes take place in their home, sometimes at a clinic, and if something's at the patient's home, you need to know where they're located so you can send the emergency treatment there if necessary.
Okay, makes sense. So I have a question from the audience, Dirk. He's asking, so can successful outcome be achieved with significant lower costs? Something supposedly just purely a 12-step program in there. Because the reason is that this will be something that's free, the competition in there. I know you talk about the fact that drug of course has a huge impact in there. Do you see value?
Yeah, that's a really good question, and I should clarify that in that 12-step slide, that study was specifically looking at a 12-step treatment model and following the patients after they left treatment.
Okay.
Saw what their follow-up was. But there are millions and millions of people that get sober through going to Alcoholics Anonymous, Narcotics Anonymous, who never step foot in a treatment center. So there are people who, that's how they get sober, and they're able to maintain lifelong sobriety without having to actually go into a standard treatment. One of the sayings of the Alcoholics Anonymous program is that it's an anonymous program. So that makes it hard to track people and determine, what the overall success rates are. So the closest thing that I could find was this study looking at the people that were in treatment and then following them afterwards. But yes, certainly there's people who, for no cost at all are receiving, good support from one another and are getting sober. It's not technically considered treatment because there's no licensed professional, there's no regulations on what's happening. So some AA meetings can be good. Some of them maybe not so good. So I also encourage people, if they go to one 12-step meeting and they have an issue with it, try another one, because they vary a lot.
Got it. So supposedly, you see probably all the news and the craziness that is happening in the Philippines, like the thousands and thousands of people getting killed. So unfortunately, the country doesn't have that much resource. And let's say you can implement this program for the Philippines, it can cost you, what will you, how expensive are these drugs? Are they cheap enough you could deploy in even places like the Philippines, or how will you?
That's a good question. So medications like buprenorphine and methadone are at this point fairly inexpensive because they're both generic. Some of the issues that we have around the world are legal restrictions on some of these medications, and that can be a challenge. Many countries, the drug and alcohol treatment system is basically in the jail, and it's not a there's not a voluntary kind of treatment aspect to it. So so that's something that, there's a lot of political issues that surround the implementation of these things. But from a cost perspective, it shouldn't be terribly expensive to implement medications like this. But it's interesting that you mentioned the Philippines, because we've actually had some discussion with folks from the Philippines about implementing the matrix model, which is a separate model of treatment that we have that's based on cognitive therapy, which has been very effective, and also can be cost effective. So yeah, there's certainly a lot of work to be done, but it's coordinating an entire system of treatment.
Okay. Yeah. Okay. So we have a question from the audience, Sehan. So he's asking, so how effective is telehealth at treating possibly the underlying mental health issues that sometimes are associated with the substance abuse? So it's almost like, can you get at the root of the issue that triggered the substance abuse?
Yeah, so that's very important. We don't have extremely good data on knowing what the effectiveness of telehealth is for treating dual diagnosis, but we can assume from other studies of treating mental disorders that when people have a mental disorder and they're stabilized, they're going to do better in substance use treatment. And we see about 50% of people with a substance use disorder that also have some other kind of co-occurring disorder. So that's a very important point, that those mental issues need to get treated as well. And some of those require medication, some of them not, but there is treatment available for that.
Okay, that's probably more like the care team model makes the most sense, right? You have a team of these to really just solve really the underlying issue, everything like fixed in one shot.
Yeah.
We have a question from the audience on Marcus. She's asking, how is the so when you issue things like Suboxone and these, how about by telehealth? How does a malpractice insurance handle this case? Are you paying extra for malpractice insurance if you do it by telehealth versus
That's a good question, and it's going to vary by your malpractice provider plan. Most malpractice insurers, as long as you're functioning within your scope of practice, in the same state as that you're licensed in, you're going to be covered. But that's something that you really need to check with your malpractice provider to see if your plan covers that.
Got it. Okay. Yeah. So we're getting down to the end of the presentation there. By the way, for the audience member, I apologize. So we probably had the most questions of maybe any webinar we had. There were so many of the party on there. Unfortunately, we will not have time to get to all your questions, but we're going to pass all these questions to Jeremy, and we're going to post the answers on the recordings afterwards. Please definitely check in on that. Again, we just apologize. There were literally, as I was seeing the questions scrolling by, it was so fast that I just definitely couldn't keep up. Again, Jeremy, thank you for presenting. I know there's a hidden topics that so many people really care about. I guess as we wrap up in there, I would like to maybe close with three quick questions for you in there. The first question is like you share so many really interesting insight, really insightful thing. If there's only one thing you want the audience to learn from you today, what would be that one thing?
I think the one thing that's really important is that even though the rates might look low, people do recover from addiction, that there is effective treatment out there. That would be my main message.
Okay, excellent. That's a message of hope and positive after message. Thank you for that. The second question is specifically within the addiction telemedicine in this area, what are something that you believe in and the rest of the world doesn't believe yet?
That's a good question. You know, I haven't heard a lot of people talking about that segment of the population, that 5.7% of people that are recognizing that they have a substance use disorder but aren't accessing treatment. And what I believe is that, you know, that is going to be kind of the next frontier for us in terms of advancing addiction treatment, because these are folks that, you know, they're recognizing a problem, and they, you know, for whatever reason, aren't accessing treatment. But I think technology may be an in, a way for them to receive treatment without having to leave the comfort of their own home.
Okay, makes sense. And the final question is, so right now on the U.S. Capitol, we're just like just all these raging, you know, healthcare debates in there. So if you could, let's say, whisper an idea into President Trump, so the senator, the key congressmen in there, like what would be this like idea they should implement that'll have the biggest impact on the like the opiate, all these issues?
I would, you know, emphasize that medications for opioid use disorders are the most effective treatment available. And, you know, we've heard from a number of people that say, you know, well, why does somebody need, you know, a medication? Isn't this, you know, exchanging one addiction for another? But the research has shown that the people who are getting treated with these medications are doing much better. And this is, you know, not a philosophical debate. This is a debate of life and death. So we need to use medications and things that are effective to treat people.
Got it. Okay. Okay. Thanks for that thoughts and the insight in there. So next week we're going back to focus on the legal aspect again. So we have a phenomenal speaker, Charles, who's going to dive into from the legal perspective on a lot of the issues on telemedicine. I definitely encourage all of you to tune back in next week. And then finally, we have our big annual conference. Will be held in the Silicon Valley on September 20th to the 22nd, called the Telehealth Failure Secrets to Success. Again, last year was a huge success. It's probably one of the best networking events. Find like-minded people. Again, I encourage all of you to, you know, mark on the calendar, plan to show up. Again, we'll post the questions that we didn't get to work with Jeremy, get posted online. So check back with us in about a week or so, get everything set up. Again, thank you so much, Jeremy, for this really fascinating, insightful discussion.
No, thank you for having me, Milton, and thank you for everyone for sticking with us and listening to this whole presentation.
Terrific. Thank you so much, Jeremy. Yeah.
Okay, bye-bye.